Heather is a physical therapist at Penn Medicine. She'll be speaking, continuing our conversation about multidisciplinary care, speaking to, how to manage these diseases from a physical therapy standpoint. So thanks so much for being here.
I just want to take a moment and thank everyone for being here. Much like the team from CurePSP said, it's really great to see people in person. We've been doing so many things virtually, but this is just kind of the meat and potatoes. Boy, it's glad to be in a room with you folks. I've been a physical therapist now for 28 years. All of my time has been with University of Penn in movement disorders. Previously served on the board for CurePSP, so I know intimately these atypical Parkinsonians. And this COPE clinic, I can't tell you enough about it, and myself and Dr. Dake and Dr. Irwin and Suzanne will be talking about it a little bit more in a group session. So please, if you do have other questions that come up for that, please do let us know. So what I thought I would do is just talk about sort of different deficits or impairments or symptoms that may be common to the particular disease process you are living with. It may not be, but these are things that we get questions about all of the time as therapists. I have the pleasure of working very intimately with our occupational therapist and our speech language pathologist, and if you've worked with any of us, you know we're all about keeping you moving, keeping you going. There are many things that the atypicals rob us of, and one of the things that we hate about this is that it keeps you from doing the things you love to do. If you've ever come to our clinic, one of the most important questions we ask you is, what do you do for fun? And that's one of the things that we want to be able to help you with doing. So that being said, I thought I'd start with blepharospasms. Blepharospasm is a dystonic event in the eyelid, which really prevents people from having the ability to open their eyelid. Can be really disabling if you're walking, if you're reading, if you're crossing the street, if you're just sitting there having a meal. So this is something that is mostly managed through our movement disorder docs and nurse practitioners, usually through using Botox. But there are things out there that are available over the counter and that you can also get through your regular optometrist or ophthalmologist. This is called a ptosis eye crutch. And basically what it is a small attachment that just goes on to a regular pair of glasses that you have, or you can get a pair that don't have any prescription in them, and they help to keep that eyelid open for people. You can also manually just take your thumb and give a little shove sometimes, and that can be helpful for folks. But again, if we can't see, we're not going to be able to do the things that we like to do. I am not promoting any of the particular devices that are up here. I just want to let you know that these are companies that we have worked with in the past and have had success with. Gaze exercises. So again, we don't have a ton of research, and I wish that we did, but we know that the atypicals are a smaller population of the diseases out there as compared to Parkinson's, and therefore we don't have a lot of research numbers in that. But what we do know is that those individuals, particularly people with PSP, do have issues with tracking with the eyes, particularly going down, eventually going up, and for some folks going side to side. So there is some research out there that is pushing forward with gaze exercises. So if you've been to a physical therapist or a physical trainer or an exercise group, we're gonna tell you to exercise the legs, the arms, the trunk, the core, all those kind of things. But the muscles also in the eyes could probably use a little bit of help. So visual tracking exercises we do with our clients, recommend that people do these daily, right? So that you're doing them just like you would do other exercises. The second one here is Post-its. I've put on the bottom here a little picture of Post-it notes, and we have letters on them. And what I have my patients do is stand in front of those Post-it notes. So we're also working on posture, we're also working on stability and balance, and then we're trying to make it fun as well. And I'll say, just with your eyes, I want you to look and spell a word for me. So looking at those letters there, we can spell cat, we can spell mat, we could spell team. So again, it's not just the boringness of looking up, looking down, looking all over. We're actually using some of the brain reserve too, so we're working on some cognitive function as well. Simply finding objects in the room. Sometimes I'll have people just stand in one spot and I'll say, all right, let's look, today is a very heavily red day, so I might say, let's look at all red objects. So I might look here at that table. I might look over there at that lanyard. I may take my gaze over there and look at that sign. I may have people doing it while they're walking. We do need something called anticipatory visual gaze, and it's something that happens that we really don't think about, and our folks with PSP do lose the ability to do this. So now you have to think about tracking and looking when you're moving. So we do practice that with folks as well. So one of the things that a lot of times incorrectly, you may have been told if you do have PSP or a condition that impacts how you track the eyes, that if you just tilt your head down, then you can see things better. That's actually incorrect in a lot of the population with PSP. This actually provokes a different response called the doll's head response. If you ever had one of those little old-time dolls where you tip the doll this way and the eyes went the other way, when you tip your head down, the eyes go up. So it actually isn't that helpful to just tip the head down. One needs to actually think about tracking the eyes down and looking down to make that happen. And I would say for folks who are newly diagnosed, this is something you should be working on now. We don't want to wait till it gets really to the point where we can't track. Let's start thinking about strengthening those now. The other thing is a simple game of I Spy. How many square objects can I find in this room? How many circular objects? And then lastly, things online. There's a whole world now. We all know with COVID how many new games and things came upon us online. So looking at things where we actually put color into things. This is a game that we use a lot in our clinic called Picturica, where you have to search and see if you can find certain things. Now, that being said, a lot of us as we age have difficulty with smaller, finer print. So we do use a lot of magnifying glasses and things to make things larger for us to see. But please, I'm here to tell you, don't discount the eyes. We still want to work on those as well. Bed mobility is probably one of the biggest issues that we hear from folks as they start to lose that ability with moving in the middle of the night, being able to get comfortable, being able to get up and go to the bathroom. Dr. Dake alluded earlier about some of the issues with the bowel and bladder with MSA. It can be common in all of the atypicals. And the ability to have that independence to be able to get oneself up, even if it's just sitting on the edge of the bed, perhaps to use a urinal or to walk to the bathroom or simply do a transfer to get into a bedside commode is very important. So a lot of times if we are not able to fix you physically, meaning we can't get you into a better position or we can't help you to get those muscles to do what they need to do, we look to, well, what can we change in the environment? And I think everybody's pretty aware of this bed rail. Very common, very easy, something for people to be able to pull on because with the bed, it's all soft and smushy and nothing to hold on to. Something that's actually newer that just came to us here is this tubular sliding sheet. It doesn't have any kind of fancier name than that. If you just Google it or you go on Amazon, you'll find this. It's sort of like the feeling of kite material. And I will tell you, it is the easiest thing to slide someone on. We've been using it to help people get in and out of cars, helping people roll over. So if you are a care partner and you need to help your loved one to move around in bed, this could be very, very helpful for you. Car transfers. For every single person who's out here, you probably came in a different car. There's cars that are high, that are low, that are too small, that are too big. You know, it's really scary for a lot of people. And, you know, I've watched a lot of folks outside of our therapy clinic because we sort of have a fishbowl of windows around us. And I watch people, you know, really struggling with getting in and out of cars. If you have been taught to hold onto a car door, please don't do that. The car door moves. You can get your fingers stuck in there. It just really isn't the safest way to do it. One of the things that we found that's the most helpful is something called the handy bar. When you open your car door, there's a little hook where your door will naturally latch onto the side of the car. This simply hooks into that and gives you something to stabilize yourself on because it's usually that push to stand that's the most challenging for our folks to be able to get up. This is the safest way to get in and out of a car. You back in. The days of stepping in with one leg are gone. I try to not even do that to get myself safe with that. It's better for the back, it's better for safety, it's better for balance. The other thing that I would not recommend that I see unfortunately a lot of care partners doing is standing in front of their loved one with both hands like this and pulling back, and I've seen loved ones go down on the ground, and I've seen the person living with the atypical go on the ground. I wish I could give you every trick that I have, but what we need to do is make sure that each and every person living with an atypical is seen by a member of the therapy team so we can really individualize this to your needs. Gait safety. We know that all of the atypicals have some component of a balance or gait disturbance that goes there. We do know that none of these are able to make us go 100% back in time, even with therapy. We're not going to be able to make the gait 100% better. We're not going to be able to keep people from falling 100% of the time. What we try to do is minimize these problems. A lot of folks end up with injuries to the arms, to the back, to the neck because of the way loved ones want to help. We naturally want to grab someone by the arm. We naturally want to hold on to someone by the hand. That's really not the best way because it's the furthest point away from the trunk, and what we want to stabilize is the hip and pelvic area and the trunk. So I really would say to most people, if you're working with someone who is starting to have walking problems, a gait safety belt. Now, some people will tell me, well, they're really uncomfortable. Sometimes they cut into me. There are soft and fuzzy ones. There are ones, back in the old days when I started school, they look like just a safety belt from your car, right? They were really uncomfortable. Things like this are very soft and plush. They even sell a vest version. So if you have someone who has really poor upper trunk control, you can hold on to that. These are also great for helping people just to stand and transfer. It doesn't mean that you need to hold on to your partner all of the time, but sometimes just to have that little bit of comfort there to know that you can grab them is going to help them to feel much more secure as well. So walking devices. I am thrilled to see many individuals in here with some great devices. There's nothing that frustrates me or probably breaks my heart more than when people say, I don't want to depend on a device. I don't want one of those devices. They're going to make me look old. What will people think if I'm using one of those devices? And my retort is always, what are people going to think if you keep falling 5 times a day? I think that probably looks a little scarier and worse than someone who's simply using a device. I see lots of people out here wearing glasses. We wear glasses to help us see better. A walking device simply helps you to walk better. And the truth is, you are going to be dependent on it. If it helps you to get where you're going safely, I am all for it. So there are many different devices that are out there. Again, I am not here to plug any of those. I think one of the things that people don't think about early on, and maybe could be the trekking poles. We're big fans of those because they have big, fat, broad tips. They help people to stand up a little taller. And a lot of people like just the way they feel and that they can still have their mobility, feeling like they have that reciprocal movement with the arms. The beauty of a walker or a rollator, and I'm going to point out this gentleman right here, his doubles as a chair. So thank you. We put the brakes on, we turn around, we sit down. So if we need a rest, if we need some support, if we need to carry something, we can also put stuff in there. So these can be really, truly lifesavers. Now, I hear the other part of that story where people say to me, well, I can't use a rollator. The rollator goes too fast and it gets away from me. I'm here to tell you that these rollators cannot move on their own. They are not motor driven. There are no ghosts moving these things. The only reasons these walkers go too fast and get away from you is because you're not using them correctly. So if you get together with a good therapy team who could teach you to use the correct rollator, and there are ways we can slow down the brakes, we can teach you ways of breaking up your steps. There's a whole host of things that we can do to help you with that. So please don't give up on those devices. I do want to go back to, I think I can go back, yep. And I may be getting ahead of myself, but there are other ways of moving, right? Just because someone can't walk as well as they used to doesn't mean that they can't get around with a power chair, with a transport chair. Maybe sometimes we use a wheelchair, sometimes we walk. You can have all sorts of flavors of mobility. So again, thinking about ways to stay active. How do I do what I love to do, and how do I want to do that? Well, if it's a device that's going to get me there, then we're going to help you to do that. I wanted to talk to you also about the excuse of not exercising because you can't get out of the house. That excuse is gone now due to COVID. So many programs came out. This was one of the great things that did come out of that. There are some things out there that I do recommend for you because I have vetted them. CurePSP TV has their own thing with Wellness Wednesdays. Please make sure you take a look at that. That is a great thing to do. And then I'm also going to give a plug to the Parkinson's Foundation. This is my partner at work, Joellen Fox. She has put forth a whole bunch of different exercises, many of them in a seated position where you can still get your heart rate up and you can still stretch your muscles. You don't have to go to a gym and join an aerobic exercise class and a stepping class and a spinning class to get your heart rate up. There are ways to do this. So if you have time to do that, and I think we all can probably find time in our days to put in maybe 20 minutes. Could you give me 20 minutes? How many people think they could give me 20 minutes a day to exercise? I want to see every hand. Come on. Even if you're lying to me, just make me feel good. Come on. Thank you. It's going to help you in the long run because I have really bad news for everyone in this room. Since you've been here, we've already aged 2.5 hours. We're all aging, so you can't forget that the simple fact that you're alive, your body is degrading. And you can change that by staying more active. So let's think about that as well. Home exercise equipment, too. You can have a lot of fun with not a lot of expense. I know that a lot of people have seen these little bikes where it's just the pedals and you pedal through. They're nice if you want range of motion in your knees and your hips a little bit. They're not going to give you a solid aerobic workout. What you're looking for is something more like this version that's up there. You want something where you can really make some movement happen, where you can really get that heart rate up there. The other thing that we love, we are certified in a technique called rock steady boxing, and it certainly doesn't have to be rock steady. It could be just simply any kind of boxing. We at our clinic bought everything on Amazon.com because that's the best price that's out there. You can do a full seated boxing program from your chair. You can kick a bag, you can punch something, you can punch an atypical Parkinsonism right in the kisser. Nothing feels better than really taking that power away from that and giving it back to you. Again, I think it's a great idea, though, that you meet with your therapist first to learn the correct ways to do these moves because you can hurt yourself with an exercise program. These small little balls that I show down here, this is a TheraBall. They come in all different sizes and weights. This is a great thing that you can do with grandchildren, with children. Heck, if you even have a dog, you can throw a ball too and bring it back. I'll take that. We need to get folks moving. The last picture I have on there, these are called boom whackers, W-H-A-K-E-R-S. These are typically used by pediatric therapists, but we have grown to love them in our clinic because each of them make a really neat tone. And if I need you to work harder than you're actually working, you've got to give me the sound of the boom and I have to hear it. And then I know that you're working hard. So hitting those together, hitting them to other things, hitting them to someone else who's holding boom whackers, you can have a really good workout from that. The other thing I wanted to touch upon, because this is really common, again, with an aging population, as well as with the atypicals, particularly with MSA, the urinary and bowel issues. I know that you think when you have to go to the bathroom a lot that you probably shouldn't drink as much water. And a lot of people come into our clinic and they don't drink their water. They hold back on it. Well, the only thing not drinking water does is dehydrate you and make you more likely to pass out. Okay, and we already know with MSA, people suffer from that condition where their blood pressure drops very low and they can get really dizzy. Your bladder is a smooth, soft muscle. If it is dry and irritated, it gets angry with you. If you keep it nice and hydrated, it doesn't get angry with you. Meaning that if it's smooth and soft and has water in there, it feels good. If it's overly dry, the next time you go to drink, it thinks you may have drunk a gallon of water when you only had a sip of water. So it's really important to get on a good drinking schedule. Good nutrition is important too, right? If we want the bowels to work well, we have to think about what we're eating, how we're preparing the food, and where we're getting that food from. We've got to avoid those processed foods. We've got to get those good fruits and veggies in there. Avoiding alcohol and caffeine later in the day, before bed, super important because that is a stimulant for the body there. Support stockings during the day. This can help. I know people aren't aware of this, but by helping with the fluid that's down in the legs, it actually has been been shown to help decrease the amount of times you need to get up at night to use the bathroom. So support stockings, I know they're a pain to put on and take off, but hopefully you have a really helpful care partner with you who can do that for you. You've probably never heard of this term, but a toileting schedule. Most of us wait to go to the bathroom until we feel it. It's really important for folks who are having bladder incontinence, urgency, frequency, to go to the bathroom at set times. That, again, it's a muscle. We can train the muscle, and then we know that we're in control and the bladder is no longer telling us what to do. There are lots of incontinence products that are out there now, so please shop around. There isn't just one right one. There are great ones for men as well as women. I know women always get the bum rap that we were the ones who needed it for so long. It impacts men just as much, so take a look out there. The last point is pelvic floor therapy. There are physical and occupational therapists who this is their specialty. This is a real high knowledge base group of therapists who teach you how to work those muscles, how to train those muscles, and how to facilitate new movement patterns within that so that you can have more control, both of the bowel and the bladder. Sleep issues, another big one. If you're not sleeping well, you're probably not moving well. And our occupational therapist does a heck of a job with talking to people about the importance of regularity of sleep. We use the term sleep hygiene, and that means go to bed at the same time, get up at the same time. If you are tired, and a lot of us are, and a lot of us nod off in the middle of the day, don't do it in the chair like this or like this. Go to bed and lie down. It's okay to take a nap, all right? Just do it safely. You want to prep for bedtime. Have a routine. Okay, at this time of night, this is where I turn off the television, I turn on some music, this is where I go and I wash my face and I take my contacts out. Whatever your routine is to set that up. Now I sit by the chair next to my bed, I'm going to read for 15 minutes, and then I'm going to get into bed. Limit the liquids at nighttime. That's the only time you really want to do that, all right, to help with that nocturia. A cooler bedroom temperature. It is better to have on heavier pajamas and a lighter blanket than the reverse, because how many of us get tangled up in really heavy blankets? We do a ton of training with people. They say their problem is moving in bed, but really their problem is figuring out how to get in and out from under those heavy blankets. So again, a warmer pajama itself and a lighter blanket. There is a company out there called Comfort Linens. It's a group that's based out of Canada, and they make these really soft, slippery bed linens that can be helpful for people to roll over in. The other thing is, I know we're all a digital world now, but if there's one thing I've learned from our OT is get off of your phone, get off of your tablet, and get off of that television at least a half an hour. I would say maybe an hour before bed. It really does overstimulate you, and we need to have that stimulation really cut down. Don't forget about music. Don't forget about meditation and thinking about our mood. If you're in any kind of counseling services or you've done meditation or you can work on deep breathing, saying a prayer, humming a tune, reading a poem, something that just quiets down your body and your mind. Dizziness. I mentioned this before, something with orthostasis or orthostatic hypotension where the blood pressure just really drops. I said this before, but you've got to drink more if you want to be less dizzy. You need to move more. All of you right now have been sitting for way too long, and luckily right after me, you're going to have a break and we're going to get up and move around. Super important. Even if you're just sitting there, you should be kicking your legs, you should be opening and closing them, you should be tapping, pumping, you can squeeze. Am I going over time or I'm doing okay? She's traveling toward me. I get nervous. Okay, I'll speed it up. You do need to monitor your blood pressure, so there are home versions of these things. Slowing down when you move to stand. There is a response that folks with PSP have called the rocket response, where we tend to stand up really quickly. That's problematic in a lot of people with falls and with blood pressure. And then sodium. So you have to talk to your doctor. I'm not going to tell you to add anything to your diet, but sometimes that can help. We were recently teaching down in Atlanta, Georgia, and they told me the 3 Ps for Atlanta, Georgia were pork rinds, pickles, and potato chips. And that's how they get their folks to do that. Limiting backwards falls. Number one thing I want to tell you, you have to work with your therapist. If you stand in front of something and you go to open it, that's where you fall backwards. This slide really shows you the importance of standing to the side of something and to holding on to something. So it may not be that we're actually necessarily improving your balance, but we're changing the way you're doing something to actually prevent a fall from happening. Same thing with limiting the forward falls. How many of us will reach for a chair because we see it, and then our feet get really small, and then we turn and we plop into the chair? We have to worry about those forward falls with injuries, so we have to think before we move. Freezing of gait. The main thing that I want to tell you here, when your feet get stuck and you can't move, and it's not just freezing of gait, it's freezing of sit to stand, it could be freezing of pulling your pants up, you have to remember the 4 S's. Stop. Stand tall, take a deep breath, shift your weight, step again. If you fight the freeze will come at you twice as hard, and the freeze will always win. Managing tone. These are just some pictures of ideas. These are gel inserts that you can put in between your toes. There are different braces that are out there. There are different stretches that are out there. Again, I say with the caveat, you need to talk to your physician and you need to talk to your therapist about that. For you guys who are supporting everyone who's living with the atypicals, please ask for help. You don't have to be alone. It's really hard to be a care partner. It's really, can be frustrating. You can feel angry, you can feel depressed, you can feel all sorts of things, and you're allowed to feel all of those things. So please look for help that's out there. Remember, you're not a nurse and a patient. You're a husband and wife. You're a daughter and a mother, a daughter and a son, and we really want to help facilitate that. Even though we're teaching you to help, we want for you to be able to find joy and fun in every day of what you're doing. These are some tips on here because you're saying, okay, great, Heather, I want to come to your center, I want to go to COPE, I want to see Dr. Dake, I want to work with all of you, but I don't live anywhere near you. Will people have copies of these?
We're all going to get, are you awake yet? Yes, we're going to be emailing the slides to everybody who had registered after this. I should have said that
Excellent,
earlier.
good. So don't have to worry about furiously writing this down. But there are resources that are out there that can help you. If you're not able to see us at Penn, we also have a list of local therapists that we use in our area. You can absolutely reach out to us. And I just want to thank you for your time. We are here to help you. Just like Dr. Dake said, if you're interested in just therapy alone, if you already have your medical services and you're interested, we see a lot of people for a one-time visit where we call it the triple threat. You see PT, OT, and speech, and then we help you to kind of set up for therapy services that are in your area. So thank you so much for your time, and we'll take some questions now.
Such practical tips. Thank you so much. I learned so much with that. We are running a little over, but again, we're all adaptable with this, so we still want to be able to give you all at least a 15-minute break. So if we could take maybe 1 or 2 questions, and again, Heather will still be here today. There'll be other opportunities. Don't all jump in at once. Oh, thank you.
Well, thanks for the presentation. You said something about walking backwards, I think, when you were talking about getting in and out of a car. I didn't really understand. If you could give a drop more detail on that.
So about preventing the falls backwards?
Where you were showing someone holding.
Let's go back.
So someone, I think, pulling out of the car with 2 hands, walking backwards.
No? Keep going.
So when you were talking about helping someone out of the car and how sometimes...
With you, yes.
Both
Please
people
don't
can
do
fall.
that. That was my advice. If someone is getting out of the car and you are the person who is helping them, please don't stand in front of them and you pull them up because you can fall backwards. There's much easier ways to do that with standing to the side of someone, and again, you can be trained. But that was my advice, was don't do that. Good.
Didn't even see you behind me. Thank you, Heather. That was a lot of good stuff. Maybe I missed it. I don't know if it was on Dr. Dyke's slide. I didn't see nutritionist in there anywhere, and maybe it comes hand in hand with the speech person or OT. I don't know, because what we struggle with my husband Jack is, as the swallowing gets worse, we have to modify the diet, no crunchy, doing smooth things, but just need more, I think, help with nutrition things.
I agree with you 100%, and the answer is we don't have a nutritionist. They're very hard to find, and what we usually do is the ALS Association always has a nutritionist on their team, and we usually go to that person and ask for recommendations in the area. The next person that we talk to is our speech language pathologist. It tends to be, if you're looking for a nutritionist, you're looking in the realm of cancer, diabetes, and ALS, and that's where you tend to find the most. I can't speak for CurePSP. Do you guys have a booklet or anything on nutrition? I don't think so.
I don't believe we specifically have one on nutrition, but
Yeah.
it's that same challenge of there's not a lot of nutritionists out there who understand these diseases, but typically it's around speech therapy to talk to you about like diet modifications. And then a lot of times I've heard nutritionists recommend the MIND diet, sort of a Mediterranean diet, high protein.
I would also tell you, look at the Parkinson Foundation. They have a lot of stuff on nutrition there specifically for PD, but you might be able to take away something from that could be helpful.
We've looked a lot with that and stay very connected to the Parkinson's group.
A lot of it is sort of trial and error with family members too.
Right.
Yeah.
Yeah, a big thing now is just with swallowing worse, eating gets so slow. So, they've all cued me and go, let him try for an hour and then assist with eating. So that's what we're to. Is there any component of the multidisciplinary program too where you have like just training and tips for the care partners?
That is a great. So at least with us, with PT, OT, and speech, we do make that a component. So our OT will bring in different devices. I will bring in different rollators, different walkers and chairs. Most of the time, because it's such a limited session where they're seeing so many other people, we'll say, hey, let's get you back in the clinic and do this, or let's get someone out into the home to kind of pick up where we left off. But I always say try it before you buy it, especially with these devices. And no offense to any of the physicians in the room, don't let your doctor tell you what rollator to get. They really don't know. Come to your physical therapist. Thank you.
We'll take one more question and then we'll go to a break. Yeah, go for it.
Thank you. Is this working? Hello? Yeah. Just a thought on the sleeping and trying to get yourself de-stressed so you can crash. There are some really great little gadgets out there today, these Alexa and Google things. I'm stressed to the max with coping with all this stuff, and I love how with Alexa I can say play ocean waves, and it's the sound of waves, or I can say play a rainstorm. It really helps, and honestly it's just a verbal command, and that's it.
Thank you. Great advice. Thank you, everyone.
Thank you.
Let's enjoy a break. We'll be around
Thank
for more
you,
questions
Heather.
later.